Well, welcome along to this month's Coaching Corner. Today's session, we're going to look at how to scan when you're evaluating for shoulder dislocation. And so this evening we have Dr. Allan Whitehead, who's a Fellow of the Emergency Medicine College over here in Australia. He'll be presenting tonight's talk.
Yes, excellent. All right, thank you, Vanessa. All right, so obviously, it'll depend on what area of medicine you're in, because not everyone deals with dislocated shoulders, but obviously it's common in emergency care, primary care, sports medicine, allied health. Something sort of procedural, diagnostic and procedural. I'll explain why it's procedural as well. Not only procedural from the terms of you might want to give something to reduce the, in terms of pain relief, to reduce the dislocated shoulder, but there's something that ultrasound facilitate, not just nerve block, but intra-articular block, which I'll get to, which sort of scaffolds on really nicely with the diagnosis. So I'm going to take you through a few cases. I think I've done about 30, like with ultrasound pictures, but I'm not going to show you all 30 cases. I think I've got about eight or nine cases, which I'll just show you representative images. And then I'm going to take you through a couple of other similar pathologies that, you can basically use the same principles for. And then we'll talk about options for pain relief prior to the attempted relocation. And so hopefully you'll learn one or two new things. Okay, so my email address is just there if you want to contact me. And hopefully, why is it might have to go manually. I'm not sure why my page down. There, it's working now. Okay, so obviously, again, this is going to depend on where you work. If you're in a large hospital or a tertiary center, you'll always have a radiographer available, and you don't need to wait for that in principle. But as we know, sometimes they're very busy, and that's going to still cause a delay. Now, so that's one issue, is having to wait for an X-ray, even if there's a radiographer there. Or if you're in a small hospital, they might be on call all the time, or even just some of the time, particularly after hours. And then it's going to cause a delay if you've got to wait for an X-ray. Could someone make sure everyone's on mute, if that's okay, please? Thank you. So, it's really good for the patient if you don't have to wait too long to make the diagnosis and get on with actually doing the relocation. And, some patients, it's easy to tell clinically it's dislocated, but then there are going to be patients that particularly large patients, where it's actually hard to tell whether the shoulder's dislocated when you're feeling the shoulder and looking at it and feeling it. And also, and obviously when it's relocated, have you got it back in? So again, ultrasound can help you with this. And there's nothing more frustrating than doing a procedure on a patient, such as relocating a shoulder, and you've given them procedural sedation, where you've got sort of a bit of a limited time to do the procedure. Otherwise, you've got to keep giving them more sedation. And then there's nothing worse than thinking that you've relocated the shoulder, and then you allow them to wake up, and then you get X-ray to take a shot, and then you actually realize, unfortunately, that you never got the shoulder back in. That's sort of something we'd try to avoid if possible. Not the end of the world, but it is a bit unfortunate in a way if that happens. So again, ultrasound can give you that answer by the bedside about whether the shoulder's in or not after you've done the procedure, if you're not certain. Okay. So some people ask about, but what about missing fractures? Obviously, in the spontaneous dislocations where it just pops out with minimal mechanism, then you don't need to worry about a fracture. Those people have obviously got lax shoulder capsules, lax joints from dislocating multiple times before, and it's not a trauma situation of any significance, so they're not going to fracture. So certainly you don't need to worry about missing a fracture with those patients with the ultrasound. Even when there's genuine significant trauma, particularly with that first dislocation, in terms of, could it be a fractured neck of humerus? Because that's usually what you're looking for as an alternative, maybe a fractured tuberosity of the humerus. It's reliable, particularly in young shoulders, young adults, very comparable to X-ray in terms of identifying whether there's a fracture or not. In the older people, it's harder because of the degenerative changes, and you've probably got about a 20% false positive rate and false negative rate combined. So it's accurate about 80% of the time. And the problem being that, the degenerative changes can look like a fracture or they can hide the fracture. From the point of care point of view, and also from the sonographer approach, we all generally agree that the posterior approach is the easiest to learn and master and the most widely used, therefore, because of that. And I think one of the main reasons is there's less structures there that you've got to identify, and particularly the coracoid process anteriorly just makes it a bit more complex. The posterior approach is a cleaner approach. One of the things that you can do, particularly in older patients who may have chronic shoulder complaints and lax joints, sometimes it's a bit borderline as to whether you think the shoulder is out or in. And we'll talk about roughly what the measurement is in terms of lining up the glenoid lip with the head of the humerus. But sometimes it's borderline. And the good thing about musculoskeletal ultrasound is in most cases, you've got a asymptomatic side, so you go to the opposite side, look at that shoulder. Often the laxity is similar. And so if you see something that looks identical on both sides, you're not going to worry about it too much. The other thing you can do is you can rotate the joint. That's the advantage of ultrasound, is you can see things in real time. So you could also rotate the upper limb and watch it articulate and move in the glenoid fossa, or hope that it's moving and articulating with the glenoid fossa well, which can reassure you sometimes if you're not quite sure whether it's slightly out. So I'm going to show you some cases now. From sort of chronologically from probably some of the earliest cases to some of the most recent cases. Now, sometimes like on these slides, I've written posterior on the slide, but that doesn't mean it's a posterior dislocation. It was because it was in my early days of using ultrasound for shoulder dislocation, and I wanted to keep reminding myself that it was a posterior approach. So that's why I put posterior there. And I'm going to get my highlight laser pointer, just to point out a few things. So remember, we're coming from the posterior approach. Actually, I'm thinking this might be I was going to do the demo later. I think I'll stick with this. What I was going to do, I'll do the slides first and then we'll do the demo. So we are looking at the shoulder from behind the patient. So you've always got to remember that. And so when you're lining up the probe marker, you want to make sure that the screen actually is visualizing to you the same as if you're looking at the patient. You don't want to be having the orientation on the screen opposite to the way you're looking at the patient. So you should always have the probe marker making the screen and the patient look one and the same. So on this left shoulder, coming from behind, lateral to the left as we look at the screen, that is going to be the humeral head more to the left, and the glenoid process fossa more to the right. So in this patient who actually is dislocated, it's an anterior dislocation, which, as we know, is far, far, far more common than a posterior dislocation. Probably, as I said, I've done about 30 cases with ultrasound, and then probably another 50 or 60 or 70 with X-rays before that. And I've only seen a couple of posterior dislocations. So 1 or 2 in 100, that's how frequent they are in my experience, very rare. So anterior dislocation, way, way, way more common. This is an anterior dislocation coming from behind the patient. So the humeral head's actually down here and the glenoid fossa's here. Now, not the best picture, and there'll be others that you'll see it more clearly. So this is sort of the space where the head used to be, and it's further away from the probe because the head has moved anteriorly, but our probe is placed posteriorly on the person, posteriorly. So the head, when it moves anteriorly, is further away from the probe. Therefore, it's deeper in the screen. Once we've done the reduction, so if we look at the right side of the PowerPoint presentation, the head is now moved from here in relation to the glenoid upwards, closer to the probe, because that's placed posteriorly, and the glenoid is here. Now, it's actually closer to the probe than the glenoid. That's actually probably most common. That's the most common scenario. It doesn't frequently line up perfectly. The majority of patients, you'll see it the head slightly posteriorly positioned compared to the glenoid. So within about a centimeter is normal. So a centimeter either way is about the normal range. So either, if this is the glenoid lip, you want to see the humeral head either less than a centimeter from that level, less than a centimeter distance, or less than a centimeter distance the opposite way if it was a posterior dislocation, because then it'll be further away from the probe. But again, we'll reinforce this with a few more case examples, and I'll take you through the phantom model as well, and how I get that view, because then you've got to understand how to get that view. So here's a right shoulder this time. So again, coming from posteriorly. So as we look at the PowerPoint presentation on this slide, the humerus is going to be more to the right side of the slide of the still image, and the glenoid is going to be to the left side of the still image. So this is actually the glenoid. This is probably an easier slide to see the glenoid on than the previous one, and you tend to get this sort of C shape that you're looking for, almost a flattened S. So that's sort of the shape you're looking for to identify the glenoid. You can see, you know, muscles and tendons stretched over the top of that. So the space where the head used to be is here, and sometimes it'll look very black from blood, from hemarthrosis. Most of the time it'll look sort of splotchy because there's clotted blood in there. And then the humeral head, you're looking for that curved shape of the head, of course, and that's sort of sitting down here. So again, this is an anterior dislocation. Can you mute if? Thank you. This is an anterior dislocation again because we've placed the probe posteriorly on the patient, and if the head's moved anteriorly, it's now further away from the probe, so greater distance from the skin, and therefore deeper to where the glenoid is. So that's what we're always looking for with an anterior dislocation when we're coming from the posterior approach. And again, the distance, you see the distance between the lip of the glenoid and the top of the humeral head is easily more than a centimeter, nearly 2 centimeters, so definitely abnormal. Once the reduction is done, which is the slide on the right, again, really nice picture, hopefully you can see that well, of the glenoid still here, a bit darker this picture, but the glenoid still here. There's the joint space, which is a lot smaller now, of course, because the head's moved into position. It is actually almost a line in this patient, but much, much better than what you had before. So we'll go to the next case. These are all different cases. As you can see, this one's still 4 or 5 years ago, or 4 years ago, but getting more recent. I haven't marked this. I have actually marked the side on this one. So this was a right shoulder coming again, posterior approach, always posterior approach. So if I'm coming from posteriorly looking at the right shoulder, the glenoid is going to be to the left of the ultrasound screen or image as you look at the image, and the head will be to the right of that as you look at the ultrasound screen and image. And again, we can see that drop down between the lip of the glenoid and the top of the curved humeral head, and it's easily a centimeter, probably 1.5 centimeters. So definitely in the abnormal range, and again, consistent with an anterior dislocation because it's further away from the probe, which you've placed posteriorly. Come to the right image on the PowerPoint presentation for the same patient, post-reduction or relocation, looking a lot better with the humeral head and the glenoid almost perfectly aligned. Again, a little bit humeral head slightly closer to the probe, slightly more posterior than the glenoid lip, which is the most common situation, but very happy that the ultrasound showing that that's been reduced. And again, in the space back here, you know, there's a bit of blood and there's clot. You're always going to get, the good thing about it when I talk about the intra-articular injection later is you're going to always have like a nice, you know, almost couple of centimeter diameter distance to aim for your injection. Okay, so a clip here and having a bit of trouble myself actually identifying the glenoid initially, but as we wait a bit, it'll come a bit clearer. And just working on trying to optimize my position. There it is. So there's that flat C or S, had to be pretty quick there, but there it is. I could freeze the image. So the glenoid is here, and the head was, again, not a great image, but the head was sort of sitting down here. There's the glenoid back up there, and the head sort of down here. And then you've got this sort of blood and tissue in the space where the head used to be. And the head's sort of a good 1 to 1.5 centimeters beyond the glenoid. Then when we go to the next image, which is still probably a bit easier for you, there's that lip of the glenoid. You can't see the full C or S, but you're seeing that sort of nice lip edge. And the head's a bit fuzzy, but it's sitting way down here. Good couple of centimeters, probably even deeper, 2.5 centimeters to almost 3 centimeters from the glenoid lip. So a really well anteriorly dislocated humeral head. Post reduction, and you can see this is a handheld probe, and it's providing perfectly adequate images to work out what's going on and work out that it's reduced. And there's a nice curved humeral head, and the glenoid lip still sort of sitting here with the space, small narrow joint space here. So well relocated. Again, head slightly closer to the probe, slightly posterior compared to the lip, but nowhere near that sort of 1 centimeter plus difference between the two. Another case, more recent again, using a handheld, and this is the right shoulder coming again from posteriorly, and the glenoid lip is sitting in here. And again, you might say, could be that line, could be that line. It doesn't really matter. You can see where the humeral head is down here, and there's a good, 1.5 centimeters difference between the level of whichever line there is the glenoid. I think it's that one, and the curved humeral head. And actually a really nice example of blood clot sitting in this space where the humeral head used to be. This joint space, again, shows you that when you do the injection, which we'll talk about later, to numb it, to actually, there's a means to reduce the shoulder painlessly. You've got a nice big target to aim for. You might not see this clot or hemarthrosis so clearly, but it just goes to show you don't have to be that precise with your needle tip like you do for some nerve blocks. Post reduction, the glenoid, that flat C or S, probably S shape better here, flat S shape. And then the curved humeral head articulating very nicely with the glenoid. Another case, I think we've got a couple more, 2 or 3 more examples, just so you keep seeing the same sort of things, reinforcing it. Again, handheld device. The glenoid is sitting in here. It's probably, again, sometimes when you're doing this in real time, it's a bit easier to see, and you trying to capture the perfect image, but it's either that line or that line. It's one of these 2 lines here. You can certainly see the nice curved humeral head, and then there's this vacant joint space here. Looks a bit gray and black, probably with a bit of mix of blood and no blood in it, and about blood clot and runny blood. And then post reduction, a bit clearer, more clearly seeing the glenoid here, and then the head is risen up really nicely, from being dropped down by at least 1 centimeter to sitting actually closer to the probe now, a bit more posteriorly positioned compared to the glenoid, which is common, but not so much that it's like 1 centimeter or certainly more than 1 centimeter difference. Even here where it looks, like it's not lining up that well post reduction, even though posterior positioning is common, you can still see that it's well less than 1 centimeter difference between the line of the glenoid lip and the top of the humeral head. So within the normal range. Okay, so just for this particular one, I just want to give you a little bit of a, talk about the circumstances of the patient before we just go straight into the image. So this man, probably, I'm trying to think, was either early this year or late last year that I saw him, so pretty recent. Young male. Clinically, he actually had a dislocated right shoulder. He wasn't a big man, and you could actually, see that it looked like it was out, and you could feel that it was out. But then I got tied up with a few other things, as you do, and said, I'll come back and we'll sort it out. And he had a pain-killing injection, but not an intra-articular injection, not anything else more fancy. He just had some, intravenous narcotic. And he was sitting upright in the cubicle bed. And I said I'd come back. I probably got delayed about, I don't know, 25, 30 minutes, something like that. And then when I came back, I noticed he was looking pretty comfortable. And I thought, well, that could be the injection, but he's looking pretty damn comfortable. And the shoulder actually looked better from the end of the bed. So I thought, oh, this is probably, popped back into place without, spontaneously, as in without us doing any active procedure to make it. And it felt a lot better. So I was thinking, okay, well, this is luckily reduced while he's just been waiting. That's a good thing. It's one less thing for me to do when it's busy. But I just thought, I took a picture, to confirm that it was back in. So I think this is a really almost textbook picture of what you're looking for. So this is post-reduction. I never got to do a reduction or a dislocation view. As I said, it popped back without anything while he was waiting. But posterior, as I said, always posterior approach. This would be the right shoulder, because the humeral head is towards the right side of the screen as we're looking at the screen, with a glenoid on the left side, and you're getting a nice picture of that sort of glenoid. You can almost say it looks like a bit like an inverted V as well, I suppose. There's the joint space there, and then the curved humeral head, and they're lining up quite well. Again, classically with the humeral head being slightly closer to the top of the screen, where the probe is a slightly posterior position, but certainly well within the normal range. And I thought, even better, why don't I demonstrate what happens with active motion, just so you get a feel. And it looks really nifty. So clips plays for a little bit, but let's have a watch. And it's really nifty to watch the humeral head articulating in the glenoid fossa, and even then watching the tendons and muscles move at the same time. So we'll just wait till that gets to the end of the clip. And so I'm sort of just starting to move it in a second. Here we go. We started moving the upper limb, rotating it, abducting it. And it's just neat how you can sort of see everything in motion in real time. Don't get to do that a lot of the time with textbook anatomy or any static imaging like MRI or CT or X-ray. So I thought that just looks pretty nifty. Okay, there we go. This one, slightly different case. I'm giving a couple of different sort of examples of things now, apart from, the classic common anterior dislocation on ultrasound. Make sure I haven't missed anything. Good. Okay. What's that? So this was a spontaneous dislocation. As we all know, we can see those as well. Middle-aged female, left shoulder, and she'd actually had 4 previous dislocations of the same shoulder, and she was doing something minor, and it just came out. So of course, not worried about a fracture at all. And this one, I believe, was actually a posterior dislocation. That's why I want to show you. The pictures aren't fantastic. We didn't bother to X-ray it because we weren't worried about fracture at all. It was just a spontaneous dislocation. So we identified it was dislocated with the ultrasound, and then we did the reduction, and then we confirmed it was reduced. So hopefully you will. What's going on? Go down. I have to go here. Why is it not advancing? Here we go. So it's just a bit sluggish. Okay. So this one, I believe it was a posterior dislocation. So left shoulder, as always, posterior approach. So that means the humeral head's going to be to the left side of the screen as you look at it, and the glenoid should be to the right of that as you look at the screen. So I believe this was the head, the humeral head, and the glenoid was down here, which means that the humeral head, is quite close to the probe compared to the glenoid, and these are centimeter marks. So when you measure that out, line there and line there, you're looking at definitely over a centimeter, probably about 1.5 centimeters, maybe, yeah. So well over a centimeter. So pretty convincing for a posterior dislocation. And she felt that was out as well. So then when we did the reduction and repeated the ultrasound, and the scale, one thing you got to appreciate is the scale is different. I've said it was 2 centimeters. Probably that might even be stretching a little bit the difference here, but certainly it's like 1.5 to 1 3/4. And then when we did the reduction, it doesn't look like much has changed, but the scale is different here. So it's 4 centimeters to the bottom of the screen and 6 centimeters here. And if you allow for that change in scale, and you measure out the distance from the humeral head to where the glenoid is, it's now, well under 1 centimeter. It's about 0.75 centimeters. So it's moved about 1 centimeter closer to the glenoid. So, that in our mind made it pretty suspicious that this was a posterior dislocation, because here it was further away from the glenoid, getting close to 2 centimeters, and here it's well under 1 centimeter, and she's feeling a lot better and moving it a lot better. So, hopefully that gives you a flavor of what a posterior dislocation would look like. Although because of the scale, it doesn't look that much different between the two pictures, but there is a significant change in the distance there. And again, these techniques scaffold on each other. So it's really good to learn the posterior approach of imaging the shoulder with ultrasound, because then you can use it to say, well, is there an effusion? Let's come from the posterior approach, do everything exactly the same, find that glenohumeral articulation. And this was the left shoulder. So humeral head laterally, laterally. That's a stupid thing to say. Humeral head to the left of the screen as you look at it, and the glenoid to the right of the screen as you look at it, getting a nice sort of flat S there, even seeing down into the glenoid articular surface. Here's that really thin joint margin, because this isn't a dislocated shoulder. This is just an inflamed shoulder with a very large effusion. And there's the humeral head. And this effusion tracked for like 2 or 3 centimeters in both directions beyond the edges of the probe. So a big effusion. And this, I just dealt with this with X marks the spot, because you've got a massive target here. It's not subtle. When they come in with symptoms, generally the amount of fluid is large. And, you don't need to guide the needle into this. It's much simpler just to X marks the spot over the deepest point, and then work out how many centimeters you want to go in. And we can count the number of centimeters here, 1, 2. So your sweet spot's going to be, I've lined up with the deepest spot, about 2 centimeters introduction with your needle. Replicate the direction of the beam, which is coming from posteriorly. Don't go to 3.5 to 4 centimeters, because you'll hit the bone and then she'll jump. So, and suck out as much as you can, because for symptomatic relief, that's helpful for the patient as well. And then sent that off. This wasn't a septic joint in the end. It was monoarthritis from gout, if I recall correctly. The other thing I wanted to point out is it's not just for shoulder dislocations that ultrasound works well, because ultrasound perceives depth very well from the skin. So the classic one you should keep in your back pocket, because X-rays are hopeless for this dislocation, is the sterno-clavicular joint, because you just can't get the right direction of the beam on an X-ray to be able to appreciate whether it's dislocated posteriorly or anteriorly or at all. And while it doesn't matter if you miss an anterior joint sterno-clavicular joint dislocation because it's managed conservatively, it does matter if you miss a posterior sterno-clavicular joint dislocation, because that can cause mediastinal swelling, tissue swelling, and then obstruct vital organs like, airways, bronchi. So you don't want to miss those. Now you could say, I could do a CT scan. Yes, you could, but these injuries happen in kids as well. And, I would certainly, not be preferring that my kids have a CT over an ultrasound if the ultrasound will give you the answer. And the ultrasound very well gives you the answer, because just like comparing the glenoid lip with the humeral head, you can compare the body of the sternum when you're in a transverse plane. So I would be coming in a transverse plane, if you can see me. Actually, I've got it on screen sharing. I'm not sure. I think you can see my face at the same time, or my body at the same time. And, come transversely, follow the clavicle down in a longitudinal axis on the clavicle until you see the step between the proximal clavicle, or the clavicle head, and the sternal body. And it should line up. The depth should be, basically the same. Even if there's a slight difference, we're talking about, fractions of a centimeter, because this is 1 centimeter here, 2 centimeters here. So you could say, oh, it might be slightly different, but we're talking about 1 or 2 millimeters, which is nothing. So I actually disproved that this teenager had a sterno-clavicular joint dislocation by using ultrasound. Didn't have to put him through the CT scanner. In fact, if I recall correctly, he had a green stick fracture of his proximal clavicle, which we also saw with the ultrasound and was not detectable with the X-ray. Okay, so when we're talking, you've diagnosed, or you've either proved that the shoulder's dislocated, or you prove that it's not dislocated with the ultrasound. So then the next things you're going to be thinking about is, well, if it's still dislocated, I want to do something about it. I want to reduce it. And what are your options in terms of pain management apart from oral and parenteral narcotics? Well, apart from that, you could do nothing else, and you could just reduce it. And that's a technique of, talking to the patient and relaxing them, and then trying to do your reduction techniques. You could give nitrous oxide, preferably the 70% nitrous oxide, because it's stronger rather than the Entonox, which is 50% nitrous oxide. And again, no issue with that. In my experience, probably works a little better for the spontaneous ones, which are easier to get back in. Just less effort to get the shoulder back in, a more gentler reduction. So I think, in my experience, I often find I must admit, I don't use nothing very rarely. It's just not something that works very well for me. But I know there are others that get 75% of their shoulders in just by talking to the patient. But I find that, I don't mind trying nitrous for the spontaneous dislocation ones, because it's usually pops back in more easily. Procedural sedation, certainly for the ones that are, traumatic, particularly often, or the ones that you've tried these other options. If you want to try those first and you haven't been able to get it in, or you just want to jump straight to procedural sedation, that's fine as well. And that's what I often did in the past, and occasionally still do. But you need a trained nurse. So the downside is this one, nitrous, you need a trained nurse or someone who's trained, whether it's another doctor or a nurse, to actually look after the nitrous and administer the nitrous while you're doing the reduction. So you need a minimum 2 people. And sometimes you'll need an assistant, to help you with the manipulation for the reduction. So 2 to 3 people for nitrous. For procedural sedation, you'll need, again, at least 3 people, because you'll need a trained nurse and a airway / procedural sedation doctor just for that part of it. And then you'll need a doctor for the reduction, and you might need an assistant as well for the reduction. So you'll need at least 3 trained people, maybe even a 4th person. So it's fairly staff occupying. Or you could do a nerve block, and there's a couple of nerve blocks that apparently work well for this area. And I'm not, I don't do many nerve blocks, and I certainly don't do these ones. So it's just what I've read. But an interscalene block or a suprascapular nerve block would give you anesthesia for this area, and you could then do reduce a dislocated shoulder. And the good news for that is you don't need a trained nurse. You can do the block, and you don't need a resuscitation bed, and you can wait for it to work, and then you can come back and do the manipulation either on your own or with an assistant. You have the same advantages with an intra-articular block. You don't need a trained nurse. You don't need a resuscitation bed. You can do the block yourself, and then you can walk away for 5 or 10 minutes and then come back and do the manipulation in that same non-resuscitation bed. I've even done it in short stay or, a very non-acute bed. But you might still need an assistant for doing the manipulation, depending on what manipulation technique you use. So just talking a little bit more about intra-articular injection for relocation of the shoulder. I use about 15 to 20 mils of 1% lignocaine into the joint space, which is now vacant because of the head being dislocated, and then wait 10 minutes. You could use a different local anesthetic agent, something that's longer acting, no problem with that. But, you know, this is going to be a successful reduction, you know, you would hope reasonably quickly. You're not going to be aiming to, you know, spend 30 to 60 minutes doing the reduction. If one technique fails, then you're going to go to another technique. If that fails, you're going to go to another technique. And by the time you get to the third technique, if it still fails, it's probably one that's going to have to go to theatre somewhere. So, you know, generally, you know, with it, you know, 15 minutes, maybe 20 minutes, whether this is the rare one that you can't get in by using multiple techniques. I think it's a really great technique if you've got a patient that's got a lot of comorbidities, they're elderly, they're frail, and there's anesthetic risk in terms of giving them procedural sedation no matter what agent you use. It's really useful if you have all your acute cubicles, particularly your resus cubicles, full. And we all know that, you know, sometimes we expect that to become vacated at a certain time, but then they just fill up straight away because more patients arrive that you weren't anticipating and you had no way of anticipating. So sometimes you can just be sitting there for ages with a patient in another cubicle to get them to the place where you can do the procedural sedation, and you just can't get them in, and they're waiting hours and hours with their shoulder out, which isn't great. And we all know the longer the shoulder is out, the harder it is to get back in. So the quicker you can actually do the technique, the better for the patient and the better for you. Or it might be that you have access to a cubicle, but all your staff, your nursing staff, your medical staff are fully occupied with, you know, one or more very sick patients, either usually in the resus area with you. So they just don't have time to dedicate the staff that you need for the procedural sedation at the time that you want to do it, and it causes delay. So again, this gives you the flexibility to be able to do it outside your resuscitation cubicle area. I've done all of mine as a X marks the spot, also called a static or assisted technique, where I'm just identifying where I want to sight the needle and prick the skin, and working out how many centimeters I want to go in, and then replicate the direction of the beam, and then slowly, as I'm pushing the needle in, I'm aspirating, and then when I think I get to the required depth, I'm injecting. And I'll talk about aspirating blood, in a second. So it's still using the same technique as we've seen with visualizing the dislocated shoulder, we've seen with visualizing an effusion. It's a posterior approach. And I will demonstrate after I get past this slide. Usually you'll aspirate blood from the joint space, but not always. They say, you know, it seems to be the textbook answer says you should always aspirate blood, but I've not found that to be always the case, and I've still had success. So don't let that put you off. And I'll give you a little short case series at the end after the demo, which shows you how often that's happened and what sort of patients I've done it on. I think that if they're very young, where they don't bleed very much, or it's been dislocated for a long time and the blood's clotted because it's been there for a long time before you've tried to do the intra-articular injection and aspirate, then in those situations, that's probably contributing to the fact that you haven't been able to aspirate any blood. You can do it in real time, and I'll talk about that in the demo. And certainly there are people who do it in real time. There is a little bit of a challenge with that, which I'll demonstrate. Sharp tip needle, it's very hard to push through the skin for this technique with a blunt tip needle like I've found. So I prefer an old-fashioned spinal needle with a sharp tip, not a blunt tip. And, you know, most of the adults you're doing it on, and even the teenagers, you know, hardly ever get a small kid. You know, their shoulders aren't tiny a lot of the time. So, you know, I think it's better to err on the side of having a slightly longer needle than you need. So I usually err on a length of about a 90 millimeter long needle, just to make sure I'm getting, often I need to get to about, you know, 3.5, maybe 4 centimeters in a big shoulder to make sure I'm getting to the spot I need to get to. But if they're not a large adult, a 60 millimeter needle would be fine. And so now we're going to demonstrate. So we did practice before you came on air, trying to make sure this all lines up. I only turned the machine off just to save battery because for some reason it was being a bit frustrating and not charging on the power, and I didn't want it to go off while I was doing it.
Alan, just tip your computer down a little bit.
A little more.
That's it. Good.
Yep. Tell me, I haven't changed the laptop angle, so hopefully that'll be okay. I'll put it back on pen and I'll turn the gain up, and we'll put it at 6 centimeters. Again, even in real life, you want to, you know, probably start closer to maximum depth and then reduce. Always a good principle. And make sure you got plenty of gel. Even the Phantom, even more so, you got to put plenty of gel on because the tissue is so firm. You know, you often have one end of the probe lifting off. So, Sue, can they see the Phantom and the machine at the same time?
Yeah, we can.
I'll have a go and we'll see how it goes. So, posterior approach. This is the Phantom. The Phantom's facing this way at the moment. We're coming right shoulder posterior approach. And I'll try and not obscure your view. Now, there is one technique where you can come along the scapular spine, which will then connect to the glenoid, and therefore you found it. I find that technique doesn't work for my brain very well, so I prefer probably this is slightly more common technique, where you find the humerus shaft and you follow it up to the head, and then you move acrosswards to find where the head's articulating with the glenoid. Now, if it's in the right position, normal position, you will see the glenoid articulating with the head straight away. If it's dislocated, if you're having trouble seeing it, that's actually a sign it's likely to be dislocated. And then you might have to do a bit of sweeping or fanning up or down to find it. So the principle is start somewhere in, you know, the proximal to mid-humeral shaft. And I'm going to just try and not obscure your view, and hopefully, there we go. So I'll turn up a bit. So the humeral shaft is down here at the moment and it's curved.
We can only see your arm at the moment.
Sorry, there we go.
Yeah.
Thank you.
Just and tip the monitor, I think, back a little bit.
Well,
No, the other way, that way. Yep.
Yep. So trying to get good contact, but there's a shadow here and a slightly curved bone there.
And the cord is also just right in the view there,
yeah.
Alan. So just lift your cord up.
Yeah.
Yeah.
Okay. So about there's the humeral shaft. You want to get it in the middle of the pitch. It's a bit challenging on this Phantom. There we go. So there's the humeral shaft there. I mean, in real life, it's probably, you see it better than that, but you can see the curved humeral shaft casting a shadow. Hopefully you can see that. Is my cord still in the way? It's a bit of a curly cord. And then from there, what you want to do, if you can see my hand, what you want to do is you want to rotate the probe so the probe marker is now up to the head, and the cortex obviously will be at the same level as what you've already identified. You could just start like this, but sometimes some people find it hard to find the cortex, and they sometimes mistake where the cortex is because of reverberation artifact, and they start too low and it confuses them. Though if you start in transverse, you'll always see the curved bone. So you're never going to mistake where the cortex is, but make sure you fan a bit, because if you're not hitting that cortex at 90 degrees, it gets fuzzy and you've got to follow it when it's nice and bright. So I'm trying to keep it bright, as bright as I can get on this Phantom without pushing the Phantom over. So sliding up, it'll just look like an X-ray. So you slide up, sorry, lots of gel on this thing. I've come off it again, haven't I? So I've got to find my cortex again, it's a tricky bit. Okay, so there's the cortex, and I slide up, try and keep it bright, try and keep it nice and bright, see it brightly. It'll look like an X-ray. You know, as you come up to the head, you get a nice round head. So this is the technique. Nice round head. Once you've centered your head, then at that point, you want to go back into a transverse plane again. So then you're going to rotate the probe 90 degrees. Now you want to rotate it such that the way it looks on the screen is the way you're looking at the patient. Normally I'd be standing here. So I'm going to rotate it so the probe marker is to the left as I look at the patient and to the left on the screen. And I've slid a bit as I rotated, but there's the humeral head. So I'm in transverse on the right humeral head now. So I was on sagittal plane. So just try and keep you a nice round head for you. It's a bit of a dippy head. Find it again. Sort of a round head there. It's a bit flat. Come across, transverse on the head now. So I've rotated, if you can see that, and you come across and slide. And this actual Phantom's actually got some joint effusion, which actually makes it even easier to see where the joint space is. So you've got the round head. You can see I'm in transverse plane, probe markers to the left as I'm looking at the probe, and then the glenoid here. So that's sort of inverted V, or sort of a flat S if you follow it along a bit more. And in a dislocation situation with the anterior dislocation, you're looking, the humeral head will be down here. And this would still be like within, probably just within the normal range. It's a bit exaggerated, isn't it? I mean, it's almost a centimeter, probably just under. So sort of borderline as to whether, you know, this would be potentially a posterior dislocation because it's closer to the skin and closer to where you are with a probe posteriorly. What you'd do then is you do stuff like, compared to the other shoulder, you'd move the limb and just see how well it's articulating with the shoulder. But up to a centimeter is normal. So that's the technique. And again, this scaffolds with effusion diagnosis, and also tapping the effusion, aspirating the effusion. So again, like you saw on the other slide, center the effusion. So you've got the deepest pocket. Normally in our symptomatic patients in emergency, there'll be even more fluid than this. This would be sort of mild to moderate. Center it, then use your probe as you're doing X marks the spot. You can do 2 vertical lines in line with the center of the probe and 2 horizontal lines in line with the center of the probe. And then put the probe down, work out how many centimeters you want to go in. So 1, 2, 3, probably about 3.5 to 4 centimeters is my sweet spot. And I've marked like a plus sign where I would put the probe in. And this is, again, replicating what you're doing with the intra-articular injection. So instead of aspirating the joint, like for an effusion, I would be injecting the joint to do the anesthesia for my dislocated shoulder. But the good news is I've got a much bigger target because I don't have to be so precise. Here I've got to be sort of semi-precise because it's not that big an effusion if I was ever going to try and tap it. But normally if it was a dislocation and the head's down here, I've got all this space to aim for. So, you know, you don't have to be that precise. You just got to estimate where you think the center of the head would have been normally and aim for that spot. So I would be having it sort of here in the middle of the screen. There's the center of the head. You know, I'd want to be, you know, aiming 1, 2, 3, maybe 3.5 to 4 centimeters in, same direction as the beam. I'm pointing the beam. Mark with 2 horizontal lines, 1 on each side of the probe, and 2 vertical lines, 1 on each side of the probe. So I'd be there, and I would inject the dislocated shoulder, going in slowly to 3.5 to 4 centimeters depth, aspirating. If I get blood, great, but if I don't let that put me off too much. And again, let's just see if this works. I'm trying to keep an eye on where I actually had marked. I haven't marked with a pen, but normally I would mark with a pen. But I think it was around about here. So let's see what happens. So X marks a spot. I've marked my spot where I want to put in. I know I want to go in about, you know, 3 centimeters. Oh yeah, I've got fluid in there. Sorry, I don't want to suck all the fluid out, but there is fluid coming up into the syringe now. Sorry, the light's not very good. You'll just have to believe me. Okay, so we'll finish up with one more slide, which is just a case series of what I've done with the intra-articular injection patients for dislocated shoulders. And then we've got time for some questions, I think. So I'm going to turn, now we've done that, I'm going to turn it back to me so I can see the screen a bit better. So case series just of the patients I've done in the emergency department I work at. About 9 patients I found when I went back through my records over a period of, well, let's see, probably about 4 years, because there have been patients in that time where I haven't done an intra-articular injection. I've done procedural sedation or nitrous. So not all of them have I used this intra-articular injection technique, but about 9. 6 of them I aspirated blood as I was going in, which is in theory what you should get, and 3 I did. 3 I wasn't able to aspirate any blood. as I said, one, when I look at those possible explanations, where one was a very young patient, another one had a short time interval between the dislocation and when we did the injection, so maybe not that much time to bleed and get a hemarthrosis, and another one had a very long time delayed sort of presentation and dealing with their dislocated shoulder. So potentially the blood in the joint space had clotted quite a lot by then. 8 of the 9 were successful with excellent pain relief and successful reduction. So I define success as both very good pain relief and a successful reduction. So it's fairly high bar, because sometimes you don't have a successful reduction. It's got nothing to do with your pain management technique. One patient who, one of the 3 where we failed to aspirate blood, I'm sorry, not one of 3, 2 of the 3 where we failed to aspirate blood, we still got excellent results. So to this stage, it hasn't been convincing that a failure to aspirate blood seems to affect both the pain relief and the success of the reduction. But there was one failure out of the 9 in inverted commas. This patient had pretty good pain relief. I might even be scoring myself a bit harshly saying moderate to good pain relief. It was quite mild, 2 or 3 out of 10 at worst, probably more like 1 to 2 out of 10. It was very comfortable at rest. It was just doing the procedure. It was a little bit more pain. And unfortunately, I was unable to reduce the dislocation no matter every method I tried, which is something that I haven't had a problem with for a long time. But the compounding factor that with this patient is his shoulder had been out for 7 to 8 hours by the time we did the injection and attempted to reduce the dislocation. And as we all know, it becomes harder to get back in the longer they're out. So I wasn't able to aspirate blood either with this patient. So this was a failure in that we couldn't get the shoulder back in, and his pain relief wasn't perfect. The fact that the pain relief wasn't perfect may have meant that he had more muscle spasm as well, which may have meant that also made it harder to get the shoulder back in. But I think time was the main issue. He was subsequently given procedural sedation as a backup plan, and the shoulder was able to be successfully relocated then a few hours later. So I think that's the end of my presentation. Oh, there was one other interesting comment I remember once I wanted to pass on. When someone was watching me I'll stop sharing so we can sort of see each other's faces. One interesting comment I had once with these patients when I aspirated blood, it was like frank blood. And I think I had a medical, it was either a medical student or a very junior doctor witnessed me doing the procedure. And they saw me injecting the anesthetic, and they go, "You can't inject the anesthetic." Like they're getting really stressed because you've got frank blood, right? And I tried to explain to them, like, I know that's sort of how you're taught when you're doing local anesthetic injections for, other things like wounds and, other procedures, that you don't want to inject directly into a vessel because then you can cause local anesthetic toxicity. But there is no vessel there. Maybe you need to go back and check your anatomy a little bit. But, the nearest vessels are like the axillary vessels, and they're miles away from where your needle tip should be. Probably any average patient, a good 4, 5, 6 centimeters further beyond where your needle should be to even get close to them in an average sized patient. And you'd have to really try hard because you've almost got to get around the bones to get at it, So I said, look, this is actually normal. This is actually good because I'm actually in the spot where the blood is, which is the hemarthrosis. But it did freak them out a little bit. So I just want to pass that story on as well. And I actually went longer than I thought I would, because I said, this is only going to last half an hour. But then I thought, I had a couple of these other things in, like shoulder effusion, sterno-clavicular joint. I'll talk about my case series. I could have gone to the literature, so luckily I didn't do that.
No, that was great, Alan. And I'm glad we had the demonstration, because I've been trying to put those images and get the spatial awareness of where the heck you are and how you've got your probe. And I think that really helped. Did anyone have any questions for Alan?
No worries, Henry. Hopefully, this will come into, handy for you. In medicine, I always think it's nice to have options. You don't have to use them all, but to have a suite of options that either work best for that patient or some of them just work for the environment that you happen to be in at the time. It's only an emergency. It's good to have the ability to be flexible.
Well, look, thanks so much again, Alan. That was really great. And I'm keen to go and have a practice scanning the shoulder now, which will be good, with a dislocation in mind rather than the normal stuff we do in radiology. If no one else has any questions, it'll be the same bat time at the same bat station next month on a Thursday evening or whatever time that is right now in your part of the world. If anyone has any ideas or questions that they want to ask that we could focus our next presentation on, be sure to send them through. Otherwise, we'll see you next time from Melbourne in lockdown once again. We'll see you again. Thanks so much.
Thanks, Joanne. Thanks, everyone.